Thank you first of all, Diabetes India, and for inviting me yet again and to be a part of this debate. Already very well defended by my friend Jagmohan. Now, my job has been much tougher. Why? Because I'll be talking in favor of BMI because I've already seen number of hands going up. So BMI is an old tool. We already know that. And the topic is regarding the DCS practice, which is more basic practice, which we have been adapting in our basic clinics for the diabetes management. So what is DCS and what we are doing for our patients? So DCS is a professionals play where professionals play a crucial role in providing personalized diabetes care and education to the patients. So it is more of a basic level when the patient's coming to the clinic, and they focus on empowering the patients to manage their conditions effectively. Now, it also helps in imparting education to patients regarding the diabetes management, including nutrition, exercise, and medication adherence to its core function. And the basic assessment are the regular assessment like patient health metrics for tracking the progress and telling them about the treatment plans. So this is more the basic idea. Now, body mass index we already know, and we have already seen there are various classifications of BMI based on the ethnicity, and there have been various cutoff values for Western and the Asian Indian subtypes. The clinical significance we already know BMI is a quick and easy tool for identifying individuals who may be at risk for weight related health problems, and it is pretty relevant in terms of diabetes care, the DCS care. Why we are calling DCS care? Because the basic primary level assessment what we'll be doing at the clinic with minimal resources available. That's very important point. We are not talking about the tertiary care clinics. We are not talking about tertiary healthcare services. We're talking about the basic level facility where we can provide good insight to our patients who are visiting to our diabetes clinic, where we can tell them something uh, over through an overview how their health condition is actually going to be, and with the help of this simple metric tool. So it is easy and it can be easily calculated and interpreted using a formula: weight in kgs by the height in meter square. Online calculators are also available, and it is easier to interpret. I have already told you there are various cutoff guidelines as per the ethnicity. Other common methods have already available, like waist circumference, which is also very useful. Rather than going for BMI alone, this can also be easily done with the DCS practice, where with the help of just a tape, and we can help the patient to quantify the risk factors, because there are a lot many patients who do come to us who have more amount of abdominal obesity rather than higher BMI overall. So waist circumference along with BMI becomes an additional advantage tool in the basic care limited setting which we can offer to the patients. Other common assessment which can be used and they are very popular these days are DEXA scans, bioelectrical impedance assessment, and then underwater weighing is also getting popular in certain studies, but there are limitations of these, believe me. Now, the regional fat distribution, the DEXA provides an overall fat percentage but may not be able to distinguish between the visceral and subcutaneous fat, which is crucial for assessing health risk associated with the central adiposity. Bone and lean mass inferences. So there are instances where potential overestimation of fat percentage in individuals with higher bone density or muscle mass have been done with DEXA. Sensitivity to hydration levels can also happen. Limited data on the specific populations, especially with DEXA, because it's an expensive technique. And radiation exposure. Now, radiation exposure is something which we cannot, of course, every single of our patients who are coming to our clinic with resource limited settings, especially in country like India, we cannot subject everyone for DEXA or such kind of radiation exposure. Cost and accessibility is another big challenge, and intra-observer and inter-observer variability is another big challenge which is associated with DEXA. Now, the BIA or the bioelectrical impedance analysis again is also very useful and is gaining a lot of importance these days. The BIA devices are relatively inexpensive, easy to use, and widely available, making them popular choice of body composition assessment in various settings. But BIA again can result be affected by factors like hydration status, age, gender, and physical activity level, reducing its accuracy in certain populations. MRI. Now, this assessment is the gold standard one because estimation of adipose tissue, it estimates the volume rather than the mass of adipose tissue, providing detailed information on body fat distribution within the body. It also accurately estimates the regional body composition, particularly the intra-abdominal adipose tissue, making it more valuable for assessing metabolic relevant body composition parameters and non-ionizing radiation, which is very easy, and these are non-harmful, and limitations are only in terms of cost and availability, restricting its widespread use. The other least used ones are like dietary recall, the food frequency questionnaires, and activity logs, which are again not commonly found, but they can be done in the cost limited settings, but they have limited predictive value. The limitations of weight circumference can be in multiple forms. The measurement variability can be there among the practitioners, leading to inconsistencies. Training and standardization is very important. Limited information provide only about abdominal fat but not overall body composition. And cultural considerations, optimal weight circumference cutoff vary across different ethnic groups, and specific guidelines are needed in diverse population once we are talking about the waist circumference. Now, patients self-reporting, they have got own problems like recall bias, social desirability, and subjectivity, which is again problems with those easier simplistic tools which we have been using so far, but they are not really effective. But with BMI in DCS practice, it is more simple and easy to do in the resource limited settings, because there are a lot of clinical patients whom we are attending on day to day in our clinical practice, and with a busy schedule like this, quick assessment needs to be done. So BMI can be calculated quickly, making it efficient for routinely assessment during many patient visit. Minimal time is required. It is simple to calculate. The formula is straightforward, and numerous online calculators are also available, and easy to interpret and understand, easy to tell our patients, and it has got a clear communication, of course. So advantage, it can be done with a minimal resource. No specialized training is required. It can be routinely adapted in the DCS practice, and it is significantly more cost effective compared to the advanced body composition analysis like DEXA and other scans, which might be quite expensive to be kept in those basic clinical settings, and not everyone can afford it. 90% of the clinics worldwide are using the BMI in DCS, and it has got a wide acceptance and availability. 95% of the hospitals in routine care in their medical centers are using and adapting this BMI, although we are debating this, and 75% of the countries are using this in majority globally. Just to tell you a basic case study, 45-year-old male with newly diagnosed type 2 diabetes presents with initial assessment. He reports a sedentary lifestyle, a poor habit, a dietary habit. His BMI, as per the height and weight, is 31, classifying him to be obese. And based on the BMI result, the DCS initiates a comprehensive weight management plan, including the dietary modification and exercise. So this is how the tracking of the BMI has been done with the help of the lifestyle intervention, and through counseling measures. The weight has been going down, and it is easier to look at it in terms of BMI, what they have shown over here. But there are concerns regarding accuracy, as my previous speakers already highlighted. It does not differentiate between the muscle mass and fat mass, potentially misclassifying muscular individuals as obese. Age and gender BMI cutoffs may not be appropriate across all age groups, and ethnicity does need to be taken into account as well. So what can be the better strategy for complementing BMI? It can be complemented along with the other assessment like waist circumference, the body composition, and the clinical judgment can be very useful by integrating these simplistic tool alongside, so that BMI usage can be enhanced at the basic level of health facilities, which the DCS person can really apply for the majority of patients. So best practices, it explains the purpose, it is using simple language, it addresses one's concerns and offer guidance which is needed for the diabetic patients at the primary level. And just to conclude, BMI is a valuable tool for DSS for efficient screening. Even in majority of the studies where the resource and the funds are limited, it can give a complementary assessment, given informed communication, and that's the reason that choosing the right method, depending on the patients, of course, and the setting is more important. It can tell us about the assessment goals. Level of precision can alter definitely by the choice of method, and of course, balancing simplicity and precision needs to be done. Wherever you only require more simplistic, cost effective measure, BMI is still the gold standard. Whereas if you really want precision driven tools, more enhanced information regarding your patient health, we have so many other methods, the modern ones which we have talked about, they can definitely act as a replacement. With this, I would like to conclude.